That's true. So I think we got the grasp of what is a clinical trial, and a clinical trial is really, we have an idea and we don't know if it works. It should go through the process of a clinical trial to be sure that what we do really is helpful. This is the gist of it. Nothing can be done in medicine. Acupuncture, venipuncture, JAK inhibitors, rituximab, everything from the simplest one to the most complicated should go through the process of a clinical trial. So right now, we will try to understand the vital role of clinical trials in everyday clinical medicine. We will see what it's like to participate in a clinical trials, the hurdles that you may face, the hurdles that we are gonna face, how to overcome them in order to understand the intricacies of clinical trials so that any one of you can have access to the most cutting-edge treatments that may help your disease, may help you. And let me share another story from my life so that we start rolling. My grandfather had cancer when I was in medical school 15 years ago, and he was treated in a big hospital in Athens, and he was offered to enroll in a clinical trial. So he refused. He was afraid, he didn't want to be tested, he didn't want to go to the hospital and again and again, and unfortunately he died. And looking back at the drugs that were offered to him, I can see that probably if he was in the investigational arm of the trial, he would live longer. These drugs are good. We know now that these drugs are very good and prolong the life of patients with lung cancer. On the other hand, from the other side of my family, my grandmother is a cancer survivor. She had breast cancer, and she's totally fine with it because of the impact of the drugs that had got approved by rigorous clinical trials. So clinical trials has so many things to talk about, even the name. I was in Spain a few years ago, and I was talking with a doctor there, and he told me that if you translate the name clinical trials into Spanish, you get something of a legal proceeding. You think that it's something that has to do with the law. So there are many things to talk about today, and the way that this is gonna be structured, we will take every step of the way and we will talk about it. So the first thing is learning about a study. Do you have any ideas? Where can we learn about the clinical studies? Where is the place? Oh, good. Please, how can we learn? So we have a condition. We have a medical condition. The first thing we should do is do some endoscopy. Are we totally satisfied with the treatment? This is not a question we should ask our doctors. Our doctor is gonna tell us that we are in complete remission. This is what the ESSDI, this is what the BILAG score says. But are we totally satisfied with our present medical condition? If the answer is no, then we should look at all the available options and talk to our doctor. I still feel fatigue. I still have some morning stiffness. What can I do? And if there is no available options, the next step is to look upon the treatments in clinical studies. How can we learn them? Where are these treatments available? Does anyone know? There is a database, there is registries that we can go and look for them. The most important and the most widely used and the most easy to use is the clinicaltrials.gov. So we can, from the warmth of our place, we can go into the internet, type clinicaltrials.gov, and we will see a search box. And there we can search for, let's say, a treatment, acupuncture, or JAK inhibitors, or TNF inhibitors and see the trials that are enrolling. Or we can search by our disease. I have Crohn's, I have rheumatoid arthritis, I have Sjogren's, and we can see all the trials listed there that are enrolling, that are actively enrolling. But if we want to be honest, has anyone gone to clinicaltrials.gov and see the registry? Yeah, it's not easy on the eyes. It's really officially made. It's not easy to navigate. It's not easy to find what you're looking for. There is so much information that you just scroll and scroll and scroll, and you really can't find what you're looking for. But there is one thing, and this is what I suggest to my patients, there is one thing that you all can find in clinicaltrials.gov, and that is the contact information. There is always contact information from the PI of the center that is right around your place, and you can talk to him, you can send him a message to the trial coordinator or the leader in the country, the national leader of the trial, and ask him anything you might think. And trust me when I tell you, he would be or she would be more than happy to answer. So clinicaltrials.gov is not a way to understand everything about the trial, but it can work as a bridge, bringing you closer to the ones doing the trial and getting to know the trial better. But there is an easier way to learn about the trials. Through your doctor. Through your doctor. We should choose our doctor wisely. And our doctor should be really abreast with all the clinical trials that are available on his medical field. And if he doesn't propose any clinical trials to you, don't hesitate to ask him, hey doc, are there any clinical trials for my fatigue? Are there any clinical trials for my residual arthritis? For my lung that has fibrosis and is deteriorating? Is there anything more we can do? So the doctor should be aware of the clinical trials that are available in your field, should always inform you about the clinical trials, and if he doesn't, you should ask him. Ask him directly. Ask him while looking him in the eyes. And there is a third way we can learn about clinical trials. Through the medical associations, through the medical organization, the patient associations. And this is in your hands. And this is a responsibility you bear. So everyone here should have a small knowledge about the trials that are right now enrolling, and this information should be disseminated in all the patients. So we can learn about clinical trials through three ways. We can learn through our doctor, we can learn through the internet by ourselves, or we can learn from the patient associations. So let's say that we have fatigue, we have Sjogren's. Sjogren's, one of the most important issues patients have, except for dryness, is fatigue, and we can find a trial that looks for fatigue in Sjogren's. What is the next step? What is the next step? The next step is to understand whether the objective of the trial is really what we cater for. In other words, every trial has only one objective. A trial is not powered enough, that's the official word, but it's not destined to answer a lot of questions. It is only powered, has the power to answer just one question. This is the primary end point of the trial. This is how you're gonna learn about it. So when you see a trial, search for the primary objective of the trial. Is this what I as a patient really cater for? Is this what I'm really interested for? The primary objective of the trial. And let me say some negative things about the trials that really are right now and in the last decade, I think, pushed by the big pharma something that sways away from the clinical endpoints to what is called surrogate endpoints. Does anyone know what a surrogate endpoint is? Surrogate endpoint, and not a clinical hard endpoint. So please pay attention. A surrogate endpoint is not something that is inherent, meaningful to the patient. It is something that instead of that has a correlation with what is important. What is important? Living longer and living better. It's not the FACIT score, it's not the ESSDI score, it's not the BILAG score, it's waking up in the morning and feeling better. That's the important thing. So we move away from endpoints that really are important, living longer for cancer, for example, to surrogate outcomes that are supposed to be correlated with the hard endpoints, but they are not. In cancer medicine, that's progression-free survival or time to progression, but these not always correspond to the time until you die. This is the most hard endpoint. And you may in rheumatology, we use the term patient-reported outcomes. This is the clinical endpoints, patient-reported outcomes. Does anyone know what a patient-reported outcome is? This is not a surrogate endpoint, it's a clinical endpoint, because it's what the patient feels. It's not something we measure that reflects or mirrors how the patient feels. So in medicine, in randomized trials, in order to understand whether a trial and a drug is successful, we use some outcome measurements. And these are kind of esoteric. And I usually, when I talk to my students, I usually use the paradigm of lupus. In lupus, we have BICLA, we have BILAG, we have SRI-4, but the patient will not come and say, you know, doctor, you changed the treatment and my SRI-4 went from 5 to 3. He will tell you that I'm run down. I can't wake up in the morning. I can't work as I used to do. This is the difference between the surrogate markers, the scores that doctors use, and what the patients are really, what interferes with the patient's life. So we have patient-reported outcomes. We have the FACIT score for fatigue. We have the FS36. We have the questionnaire about the general health assessment, the HAC questionnaires. And these should be the primary outcomes of our trials. And instead of moving towards that direction, does anyone know the TULIPs trial for lupus? TULIP 1 and TULIP 2. Does anyone have lupus here? Yeah, TULIP 1 and TULIP 2. This was groundbreaking, huge headline trials that showed that anifrolumab can be used in lupus, especially in cutaneous lupus, but all the patient-reported outcomes were withheld, were upheld, and were not published in the final papers 2 to 3 years ago in the New England Journal of Medicine, even though through clinicaltrials.gov protocol, we know that they have the data. The pharma industry decided to withhold the data of patient-reported outcomes. So you know the scores, you know that the doctors are satisfied, but you don't know whether the patient is satisfied by the new treatment that Code approved. And now it's a very good treatment, but we should sway away from surrogate markers. We should sway away from what what doctors think is important to what patients think is important. So we learn about the trial, we see the primary objective of the trial, and we are interested in the trial. So we go to the doctor and say, hey, doc, I have Sjogren's, I have fatigue, I see this trial that involves yoga in Sjogren's, I'm interested. Let's go. And the doctor hands you a huge document, 70 pages, and says, here is the informed consent. Please sign here. Has any one of you participated in clinical trial? Do you remember the informed consent? Did you read it? You did? Oh, that's good. Oh, that's good. That's not representative of what happens in everyday clinical practice. I have one word for informed consents. It's ridiculous. The informed consents are ridiculous. And first of all, let's paint the picture. Clinical trials are they search for volunteers. There is no obligation, there is nothing mandatory. While you participate in a clinical trial, everything you do it because you want to. And the doctor will give you that informed consent that is just to inform you about the procedures of the trial, and you will put your signature in. There may be someone watching you, and you might think this is a legal notice or a legal contract. It's not. It's not. Anytime you decide, even before the trial starts, in the middle or after the trial, you can say, I don't want to be part of the trial for the XYZ reason. You don't have to feel ashamed. We see that there are patients that happen to move away from our medical center, and they call us and apologizing to the doctor. I want to get off the trial, to bail out of the trial, but I'm afraid to tell you. It shouldn't be like that. It shouldn't be like that. It's your body, it's your disease, and we are just there to shepherd you along the way. You participate in the trial because you want to, and you can get off the trial anytime you want to, for any reason. So the informed consent, when I give the informed consent to patients, most of them, not all of them, but most of them, like deal with, you have your iPhone or your phone, and there is an update, and you get terms of agreement, and you scroll, and then you say, I agree. This is how most patients deal with the informed consent, and it shouldn't be like that. The informed consent is not something that can be read in one sitting. You should take the informed consent and go home, or be sent to you by the doctor. That's even better, when you are home, so that you have the time to digest and navigate through all the information. It's impossible to do it in one reading. So you start reading it part by part. You can advocate from a patient and have some advice from a friend that may take part in your medical decision making. It can be a nurse, it can be a pharmacist, it can be your doctor. You can ask about things in order to understand them better, and you can always go back to your doctor and make a small summary of what you have read, leaving all the numbers and all the details aside, in order to see if the doctor and you think of the trial in the same way. But informed consent is not easy. Informed consent is important. It's important for the doctors. It's important for the medical part of you. First of all, and why? You may ask why. Why do we have to do all this fuss, all these huge documents at 70 pages? Why not be 1,000 pages or 500 pages? It's to ensure, first of all, that you will be treated exactly as the next patient and the next patient and the next 100 patients, so there is a homogeneity among the patients. Everyone, it depends on the doctor, but the structure of the discussion and the structure of how everyone considers the trial is pretty much similar. This homogeneity, this balanced, fair and equal process is important for the patient, is important for the caregiver, and make them feel confident that they get the same information as the next patient and the same information as the previous patient. And it is important for doctors to document that the discussion has been made. The documentation is very important, because not every clinical trial goes smoothly. Clinical trials have problems. There may be unexpected side effects. There may be side effects that are expected by a much higher frequency than before. So we may end up halting and having an audit by the regulators, so we should have the documentation that everything happens. The patient was informed, the doctor informed the patient, there was the signature of the patient, every procedure went as it should have went. So the informed consent, I think it's something that should stick with the clinical trials. It's not easy to have a clinical trials without an informed consent, but we should make the informed consent more easy to be understood by the patient. We should use lay language. We should make the informed consent, not like a legal notice using difficult language, difficult to understand terms, very easy to understand all the procedures and be able to agree or not in taking part of the clinical trial. So any questions up until this point about the informed consent, about learning about the trial, the objectives?
Maybe I don't have the questions, but I wonder sometimes what is the benefit of the patient of this clinical trial. In Montenegro, we are not started so much in this way, but I know what you're talking about, but what is the benefit? People are afraid about these things, don't know. When you don't know something, you are not involved, never. This is the big problem, and you in the start in your
Presentation, yeah, and the discussion.
you start with your father with and people don't know and afraid about everything. Clinical, when you said clinical trial, you said, no, it's not wrong. He or she don't know what is it, but don't involve. This is the big problem. And also, the patient must know what is the benefit for people. I'm very loud, you know. I speak very quickly. The question is, my question is, it doesn't matter. I'm very loud. The question is,
You can use it.
your.
Yeah.
No, because I listening very carefully. And what is the benefit for the patient?
Yeah.
The first thing is what is he thinking or she, what is my benefit? What I get that for this?
The PI, the question is, what's the PI? That's an easy question. The PI is the principal investigator. This is the leader of the trial. Every center that gets involved in the trial, and come back to your question, we're going to talk a lot about it. Every trial, every center in a multi-center trial has a leader. This is called the PI. Is the leader of the clinical trial in that center. Another center has another leader. So we have, every center has the leader. We have the national leader. So let's say Greece or Israel might have 10 centers. Each center has its own PI, and there is a national leader, one leader for Israel, one leader for Greece, one leader for Montenegro, and it goes like that. And there is an international medical leader for Europe, for example. And always there is the study coordinator. This is usually coming from the sponsor. He coordinates all medical centers. So we start with the PI, national leader, international leader, and study coordinator. So what's the benefit of the patient? You really scratch the surface of two different things. First of all, the thing of inertia. If no one is into clinical trials, how do we convince people to learn about them? How do we convince this machine of clinical trials that is helpful for them and it's helpful for the community? How can we make this machine working? And this is, I think, this is the most important role of patient organizations. Patient organizations should really, yes, make them feel close to the clinical trial process, clinical trial machinery. Make them understand what are the benefits for the patient and what are the real benefits for the patient. What are the real benefits? First and foremost, patients get a new treatment. Hope. Patients, through a new treatment that they are interested in, they get hope, but also they get a treatment. It's not just hope. that their situation, their medical condition may be improved. So yes, you get a new treatment. This treatment might help you. This is easy. What else? What else?
Must the patient learn to put from the mind out, I am not animal?
No, you're not a guinea pig. You're not a guinea pig. It's not a last-ditch resort. No, it's not the last thing you can do before you go to hospice. Clinical trials is not like that. We should say that. I've said that in my clinical practice thousands of times. Patients come and tell me exactly that. We use mice in the Greek language, not guinea pig, but guinea pig in the international, in the language, in the English language. No. What we do is on top of your care. On top of your care. We don't disturb your medical care. We don't disturb your treatment. How would you be treated otherwise if you were outside of the clinical trial? You take the same medication if you are in the control arm. So you will not be untreated. You will not be left alone. This is the most important thing. What we do nowadays in clinical trials is very different with how clinical trials were structured 30 or 50 years ago. And there are more benefits.
So if we still have the treatment.
Yes.
And we are trying for new treatment. We are in the clinical trial. So don't you think there will be some kind of interaction because of your treatment, usual treatment, and the new treatment? You explain, please.
So there are two arms. Patients that get involved in late-stage clinical trials, phase 2 or phase 3, this is the most important, get split into two groups. The first group receives the standard of care. This is the control group. These patients take the placebo. The placebo, what is the placebo? Sugar pill. The sugar pill. But they also get the treatment that they deserve. And to make it, to understand better, let's talk about cancer. Because cancer is, you have a hard endpoint, that is death in a few months. So you get enrolled in a clinical trial for pancreatic cancer. You have a prognosis of 1 year. You deserve a treatment. You deserve chemotherapy. So you are split into two arms. The first arm is gonna get, the placebo arm is not gonna get the new pill, he's gonna get the IV chemotherapy. The other arm is not gonna get the IV chemotherapy, he will get the new treatment that is supposed to make him live longer. Is he gonna live longer? No one knows. But nowadays, clinical trials that end up and they reach the phase 3 stage, usually they're gonna be similar to what's already on the market. I don't know if they're gonna be better, but they are not gonna be worse for the majority, the vast majority of cases. So you are not getting both treatments. You're not getting both chemotherapy and the new treatment for pancreatic cancer. You happen to get either the new treatment, but the placebo arm still gets the chemotherapy he deserves. So you will have close supervision. That is another benefit of the trial, and I'll come back to you. You will be very closely supervised when you are in a clinical trial. You will see your doctor every 2 weeks, every 3 weeks. You're gonna talk. Your doctor will be probably the best in your country for that disease. His medical team will be next to you. So this is a benefit. So you get a new treatment. You get a medical team that will give you his personal phone number that you can call anytime, because this is what a clinical study means. It means that anything that happens to you should be your doctor and the medical staff and the whole team, the study nurse, should be informed about it. So let's say an example. You are in your house ready to go to get the intervention and the investigational treatment. And you happen to have an accident while driving. Is this related to the clinical trial or not? And you get in the hospital because you have let's say, broken your leg. Is this related? Should your doctor be informed? Yes, of course. Yes, of course. Whatever happens to you while you are in a clinical trial, even if it's considered like this has nothing to do with the clinical trial, it's not that I caught the drug, I felt dizzy and I had the accident. No, the road was icy because it was snowing and we had the accident. No, it's related. It's related and should be write it down. Because if this is an exaggeration, but if you, let's say, we have 10,000 people in a clinical trial and 300 of them have an accident, because of the accident and because you make people come and go from the hospital too many times, the whole benefit when you weight everything may be negative. So you should be informed. You have a medical team right by your side at the whole time, at this whole process. I mean, the personal phone numbers, and you can call them at any time, and they are obligated to come if you are hospitalized in another hospital or take you back in the center and take care of your care, whatever happens. So the benefits are feeling having the hope of a new treatment, having a medical team that's right beside you, and this should be, this is what we as doctors and you as medical associations should tell to your patients in order to make them take part in the trials. But there are also economic benefits, financial benefits. The treatment is going to be for free. The blood tests, diagnostics tests are going to be, some of them are going to be for free or waived. So there are some things that have a financial impact for the patients, while on the other hand, there are some extra costs. There are some extra costs involved because you will have many more visits in the medical center. The patient would normally come once every 3 months. Now he will come once in every 15 days. That means extra costs for traveling, extra time. This is the truth. This should be discussed. The logic of clinical trials is to be financially neutral. So if it was to have an examination, let's say a CT scan of the lungs, your Medicare is going to pay for that. But if in the subject of the medical trial we need an MRI of your earlobe every 3 days, this is going to be paid by the sponsor, by the clinical trialists.
Sometimes you are facing a situation, it's from life experience, that the trial process didn't finish yet. But someone needs the medicine, and you feel you are the PI, and you feel that the result is going to be good. Do you recommend to take it before the trial is, you understand the question?
No, I just want to make a small comment and come back to you. The PIs of the study are not allowed to feel that the drug is working. The PIs of the study and the whole team of the study should be equipoised. This is the word. That means that this should be neutral. They don't know, they still don't know whether the drug works, and they shouldn't handle the drug as if it worked. Because if it worked, we wouldn't need this trial. So the PI and the whole team should, and this is very important, should remain neutral when it comes to the efficacy of the drug. No, that's why it's double-blinded. The doctor, no one knows, not even the doctor, not even the sponsor, not even the statistical team behind the Novartis company, no one knows. We usually look at the results of the study at 2 time points. The first is the interim analysis. This happens right in the middle of the study. This is where we look not for efficacy, not for whether the drug works, unless we have some fantastic results. if we have some fantastic results, we can get what is called accelerated approval. We can stop the study is supposed to take 3 years, and in 1.5 years, we can say that this is fantastic, and we cannot withhold it from the whole world because the results are super satisfactory. So you end up the trial in 1.5 years and the drug gets approved. This happens rarely. So the PI is not, unless this is the situation, he is not aware of the results of the interim analysis. He is not aware of the results because he will be biased. He will be biased. He will see a patient taking the control group, or he will understand if it's a single blinded, or he may understand from the how the patient, how the clinical trajectory goes, and he will tell him go away from the trial. No, this is not how trials are supposed to be. Doctors should be equipoised. They should not be determined that the new treatment works. It's very important because if the doctor destroys this equipoise, he will interfere with the results of the trial, and having the best results is the most important thing. Yes?
You forgot. It's okay, you get carried away. It's a very interesting subject. Thank you very much for sharing all this information with us. I go back to the study design. Well, I'm Victoria Masala. I lead physiotherapy services in Malta. Thank you so much to Aram for this invitation. I go back to the study design. Maybe you can advise us all a little bit about the time. Because you said this trial might make you live longer. So here we're looking at longitudinal studies. So how long, what is your advice about how long the trials are taking place? Thank you.
You think of it much from the rheumatologic perspective. In rheumatology, trials don't look at the longevity, at how long people live, because in general, we and you live pretty much as long as the total population. So very few clinical trials in rheumatology look at longevity, look at hard outcome of death. The exception is Pexivas. Does anyone have a vasculitis in here? Vasculitis? No, vasculitis is a disease that we have some hard endpoints. Pexivas was a huge study published in 2020, and the primary objective of the trial was a composite of death and end-stage renal disease. So this is a real hard point. We cannot see this kind of endpoints. It's very difficult to do a study for 25 years, so you have a patient with rheumatoid arthritis, he's 30 years old, she is 30 years old, and you will follow you will follow her up until she's 99 years old and she's gonna die. No, this is impossible. So death is not an outcome for most rheumatologic studies. We don't look, we don't search unless we have vasculitis. That's the only exception. We don't look for longevity when it comes to life expectancy. So what is the proper duration of a clinical trial? In my opinion, this is not something standardized, but in my opinion, in rheumatology, I would think 2 to 3 years. 2 to 3 years. If you see a clinical study that is less than a year, don't buy the results. No, I wouldn't think that the results are really something that you can trust upon them. If the clinical trial is less than a year, you don't see the full effect of treatments. It's very short to see any treatment effect in less than a year in rheumatology. And the effect, the most important question is, what is the effect? What are you waiting to see? And this is, in rheumatology, another aspect, the difference between damage and activity. We have diseases that cause damage, and damage is very difficult to repair. So what do we expect? How much better do we really expect you to feel? This is $1 million question. This is not something that I can really give you like a clear answer. I'm coming back to the most important question. What is the benefit for the patient? So the benefit is hope. psychologically. We want that placebo effect. It's not negative. We want a patient with Sjogren's or a patient with ankylosing spondylitis that has very low CRP level, but every morning he still feels stiffness in his back. Hope that he will probably feel, he may feel better by swimming every morning. And he can do a clinical trial about that. It's not, the clinical trial, it's not always pharmacological, it's not always drugs anymore. And we can see a lot of new trials, and this is very good. We can see trials about food. How much food should we take? What kind of food should we take? Nutritional trials, this is how they are called. Or we can see trials about exercise, stretching, yoga, especially for ankylosing spondylitis. We can see lifestyle changes that don't interact with the main treatment strategy, with the main treatment regimen. So hope, so financial benefits, the patients will have some financial benefits. Being closely monitored by their medical team at any time, 24/7. And I think the most important, I was taking part in a similar conference, and there was a big research done in the United States. They asked all patient organizations that took part in the trial, what is your most important reason for taking part in this trial? And 40% of them, and I was surprised to see that, they answered that they take part in a trial because they want to help. Because they want to help. Because being part of a clinical trial, you are part of the new treatment regimen that may change the medical field, may help a lot of patients, may help you, but not only you, may help the community.
Thank you. I think it's interesting that you got to the help. I would call it a contribution. But having been like a long time, I've been cooperating with, supporting the Estonian Rheumatic Association. And I would add as the benefit of seeing the ones who participate that they actually have higher awareness of their disease. And it somehow becomes about not only me, like protecting my life somehow, but it's somehow, on one hand, is contribution, awareness, but also somehow making it into benefit. Like that my story becomes a benefit of bigger, and I see that somehow it raises this kind of importance that I become like also in some kind of specialist, but I see that there is this like awareness attitude, but also really this kind of confidence result in everybody who participates in them, that they somehow become more equal, that they're not just like victims of the condition, but it has been very interesting to see this kind of like identity change somehow.
Couldn't say it better. Exactly. You hit it in the head. This is exactly something that is. It's not something that you can understand unless you see it. And it's if you have like if you are a doctor and you have like a small group of patients, and if one patient gets involved in the clinical trial, it's gonna be spread like a small virus. Like people want to contribute if they understand what they are involved. So I think that people do not participate in clinical trials because they don't know, because they don't feel they know the process, because they are afraid, because they haven't understand what is involved in the clinical trial, because they don't understand the benefits, because they don't understand, they are overly afraid of the negative stuff of the trial, and by this kind of communications, people will start enrolling, and this is gonna be, again and again, you'll see more and more people. Education, yeah.
If someone gets involved in a clinical trial from abroad, we go under this register, the website, we investigate. What steps, if I get involved in a clinical trial, what steps should I take in my home country? Should I inform my doctor? should I, what is your advice? Because in Malta, I'm not aware of so many clinical trials which are taking place, or if I go to my doctor and I ask him, what is happening,
I was expecting this question, and it's really hard to hear, and there's no easy answer, because if we talk about a phase 2 or a phase 3 clinical trial, the answer is you probably can't. You probably can't be part of a clinical trial from Malta when there is no medical center that supports it in Malta. So there's no such thing as being a part of a clinical trial from abroad, except it's observational trial. So you can give all your medical records and see some observatory effect, but this is different. This is lower level of evidence. The most important thing is to be part of the clinical trial. If that is the case, I don't know, there are places that really are outside of clinical studies. I don't know if Malta is one of them. But if that is the case, again, there are things that you can do. As patient associations, you can go to your doctor and ask them to cooperate, and ask them if you have like a team of rheumatoid arthritis patients or a team of Sjogren's patients. It's very easy. Companies are searching for places to get them in their team, to get them in their medical team, and so that patients because they need more patients, they need lots of numbers of patients. So the way to deal with this problem is to go to your doctor and tell him, please, not you alone as an individual, but as a medical association. We have a big association of patients with rheumatoid arthritis in Malta, with Sjogren's in Malta. We're interested. We want to be part of clinical studies. We want to be at the edge of medical innovation. Please contact the company and ask for eligibility. Please contact Novartis, please contact Amgen, and ask to be part of the new trial for Sjogren's, for rheumatoid arthritis. I bet $1,000 they will say yes.
Yes.
So it's a matter of organization. You cannot take everything in your own hands and say, I'm going to participate in a clinical trial from Malta.
Can I ask then, because I've heard so many about all these different aspects, like as a doctor, would you say that asking a doctor, are you involved in any kind of clinical trials, is some kind of a way to also evaluate how aware the doctor is of these kind of very modern things? Like if there's a doctor who is sort of not involved in any kind of study or research, that they might actually be out of date. That can it be some kind of criteria? Because there is very often a recommendation to patients, like choose a doctor well. But I mean, you know that this is actually not easy. It takes a lot of awareness also. But can this be one criteria to show that the doctor is modern?
Definitely yes. Definitely yes. And I'll be harsh on doctors. Yes, they should be aware of all the clinical trials, that you, as her patient, as a doctor's patient, can enroll. They have to. They're obliged to, and you should demand it. It's not something to ask politely. It's on our medical duties. Clinical studies is not something that it's outside of the medical students and only the best doctor should offer you. No, everyone should be aware about clinical studies for his medical field, not for everything. Like I work with Sjogren's. I should know every clinical study right now enrolling for Sjogren's. I work for rheumatoid arthritis. I should do the same. And it's not easy for the regional doctor to do that. But you know that there is an expertise center in each country for a disease. It's not a European reference center, but a national reference center. There are some doctors, they should know, and they should be, and their team should be part of the clinical trials. If not, yeah, it's something that should be taken into account when you judge how satisfied you are from the medical care you get from the caregiver, from your doctor. Yes, Definitely, definitely. Any more questions, or we should move on? But I think it's better to do it like this, like a discussion. So informed consent, and then there is the. They're not. I said it previously in the presentation. Not everyone can be involved in a clinical trial. There are some selection criteria. And what do you think? A trial should have a lot of eligibility criteria or very few eligibility criteria? How do you think about it? Like, should we search for a 35 years old Olympian who can run 42 kilometers in 5 hours and he's high and tall and handsome and has some rheumatoid arthritis? Should we search for this patient? Or we just say rheumatoid arthritis, just don't be like a child, get just the edges outside. What do you think? Yeah, clinical trials should represent the real world. If we want the clinical trial to be utilized in the real world. If we are looking for Olympians, then only Olympians will take the drug. We should look, in clinical trials, we should look for everyone. The eligibility criteria, and I think that we move towards that direction. The eligibility criteria are less and less year by year. We want more patients, we want practically every patient. Sometimes there are some exceptions. We usually can leave outside patients with very, very, very severe forms of the disease, the 1% that may have very, lupus, and central nervous lupus involvement. Because in these patients, the benefits of taking the new treatments towards the risks may not be on their side. So these patients with very, very severe manifestation of the disease can be left outside because they are a group on their own. And clinical trials should be designed based on this specific group. And the other thing is that we want some homogeneity. We want these 1,000 people to have some common elements. If there is a disease, a very multifaceted disease that has many, 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 many different iterations, many, many different clinical manifestations, either we want many patients or we want many studies. We can look only with patients with lupus and kidney involvement, only with lupus and skin involvement, only with lupus and blood involvement and cytopenias. Or we can do a big trial of lupus and put everyone in the basket, but in that occasion, in order to include everyone, we will need 10,000 people with systemic erythematosus. Duration and size. We talked about the duration. How about the size? Is always bigger the better? Is big trials good or big trials bad? This is a tricky one, and I want to listen to how you think about it. So we have a trial for rheumatoid arthritis, and we look at FACIT score, a patient-reported outcome, perfect. Should the trial be how big should the trial be? Nobody knows. Yeah, that's one way of thinking about things. But how do you think? What do you think? What's the risk of having a really big trial? Let's say
It's too long.
I include 100,000 people with just the FACIT score. No, the duration is 1 year. You mean the enrollment? The enrollment?
3 years.
Yeah, but we have Novartis, they have money. They can manage everything. Trust me when I say that. They can do anything they want.
I'm Ivanka from Bulgaria, Bulgarian RMD Association. Here comes the medical statistics and in statistics in general when we speak about sizes. So from above a certain number of people, you won't get any different results. For example, if you have a study from 5 people, you may not be able to cover all potential benefits and risks. If you have a study of 100 people, then statistically you can probably cover everything, but not quite sure. And if your group consists of 1,000 and more people, and it's quite representative from the general population, then you can be quite certain about the outcomes. That's the way every statistician, every marketing person, or I don't know, every sociologist measure the things.
Yes.
I think it's the same, more or less the same.
Fantastic. Bingo on the way you think about things. Yes, large size gives precision to your results. The confidence you have, if you have a large size, the confidence you have on the final result, does this drug help me or not, is better, is more solidified, is more structured. However, and listen to this carefully, it's very nice to understand, if you have a very large trial containing loads and loads of people, you run the risks. Okay. You run the risk. We have the afternoon, we have the night, we have lots of time to talk about it. You run the risk, and please listen to this. You run the risk to find statistically significant differences that they mean nothing to patients. So you have the power to detect differences. I'll give you one example from the cancer, world. You have treatments that prove to be statistically superior than the standard of care by 5 or 10 days. Is this important for patients? To have a new treatment, spend billions of dollars to live 5 more days? Or in rheumatology, you have the FACIT score, and you have, there is a scale. You go, before you take the treatment, you have 6.5. After the treatment, you have 6.2 score. And the statistician tells you that this is statistically significant. But is it meaningful for you? Are you going to feel any difference if you have a 6.2 or a 6.5 kind of score? No, it says nothing. That's why we need minimally, clinically important differences. We don't care about the patient, we don't care about statistical significance, so we don't care, we don't want to oversize the study. We don't need thousands of patients, because we just need to reach that minimally clinically important difference that we know in the FACIT score is a score of 2, not 0.0, just 1 minute, not 0.3. So we are looking for the perfect size, and it's also that oversizing puts patients at risk. We want the less possible size that can prove the minimally important difference.
Example, drugs must be approved. What is the minimally? To Ministry of Health must approve. And that's why maybe it's good big trial, because of people know that is what 1,000 people involved in these drugs, it's okay. And example, 80% people is everything okay, 20 is like this, but it's anyway be approved. Everybody know. Even in Budapest, I remember 10 years ago, we were speaking about biosimilar therapy. When I asked it, it is approved, it is make some exam of people, no. And I never choose to come again, because I put some good questions in the right position, because I'm not interested, because the medical, even a lot of these medical houses don't like the people who a lot of ask. Fortunately, this is the way.
I totally agree, and I will close with this. Yes, size matters. Yes, we need big studies, but we don't need oversized. There is a limit. There is a limit because if we have too large trials, yeah, we try to find the right balance. If you have too large trials, thousands of people, we may get the regulators might think that the trial is positive, but the impact on you, the impact on the patient is so minimal that he doesn't experience it. No. It's the study coordinator. There is a statistical process to end up with the number of people you need in the trial, because it's not, if you want to see whether, you ask a question, does anifrolumab improves the lupus score by 20%? You ask that question, and you go to your statistician and ask the effect, the number of people you need in order to answer this question. And the duration. So it's like a mix, a hybrid of the PI of the study that knows the disease, hoping that the new drug is going to help people, and enrolling as low. The threshold should be as less people as possible in order to take part in the trial, because you don't want to put into risk of getting a trial as many people as possible, because you don't know if the trial works. If you are confident that the trial works, you break the equipoise and you are not a good PI. I think we should call it off for the noon.
Yes, because we are going.
I can see some signs back there. I am afraid for my life. See?
Close, yes.
It's just open discussion, you know?
No, it's an open discussion. How to go? I know, it's all of the night.